Um, just by way of introduction, my name is Russell Michelot. For those of you who don't know me, welcome to this program. Typically, our chapter president, Judy Alden, makes some initial remarks and announcements at the beginning of programs. But unfortunately, Judy is experiencing some laryngitis today, so I'm going to fill in for her. Couple of words about Zoom and how we'll proceed today. First of all, except for me, I think everyone is now muted. At the bottom of your screen, on the far left, there is a mute, unmute button. It looks like a microphone. Please note that there should be a slash going through the microphone symbol. To speak, you will need to first unmute yourself so that everyone, including our caption provider, can hear you. To do so, click on the mute, unmute button. You'll know you've unmuted yourself when the slash mark disappears. But until we recognize you to make a comment or to ask a question, please keep yourself muted so that we're not distracted by unintended background noise. We are providing captioning for today's program. If you are not seeing the captions but would like to, move your mouse to the bottom of your screen where you saw the mute, unmute button and click on live transcript or closed captions. Different versions of Zoom have one or the other, but either I think, should work to enable you to see the captions. If you have questions or comments during our presentation, please put them in the chat box, which you can also find at the bottom of your screen. Click on the chat box, type your question or comment, and then hit enter. And when our speaker has completed our presentation, we'll go through the questions in the chat box one by one. Today's program is the last one before our annual summer break. We'll resume more or less monthly programs on Zoom in the fall. We have also scheduled an in-person picnic/family fun event for the afternoon of Sunday, September 10th in a lovely park setting in DC. For that program, the whole family is welcome. Information about the picnic, chapter-sponsored programs on Zoom, and other things of significance for people with hearing loss will go out to everyone on our mailing list as the dates approach. If you're not already on our mailing list and would like to be, please email us at HLAA-DC CHAPTER. It's HLAA-DC chapter @gmail.com. That address I have put in the chat box as well. One other important event, HLAA's National Convention will be held at the end of this month in New Orleans. There is still time to register for it, and having attended several of HLAA's previous conventions, I definitely recommend it. It's a great opportunity to hear expert presentations on many subjects of interest to people with hearing loss. And yes, you will be able to hear them, as all of the convention venues will be looped and captions for each event will be provided. The convention also attracts a wide array of manufacturers and distributors of all kinds of hearing assistive devices and service providers. So it's a great opportunity to learn about emerging hearing technology, to talk to people involved, and to see demonstrations. Last, but certainly not least, the convention this year is in New Orleans, and that in itself is a great attraction. So if interested in attending, go to HLAA's national website. That's www.hearingloss.org, and hearing loss is one word. And you can register there. And again, in the chat box, I've indicated, put, what to click on. to register for the convention. But please note that registration is still open. Registration for the convention is still open, but it will be it will only be open until this coming Friday, June the 9th. A word about HLAA membership. If you've not already joined HLAA in this chapter, I'd like to encourage you to do so. This is important as it enables us to continue providing programs like this one and to reach out for people who need hearing information and support, but for one reason or another are not able to get it through programs of this sort. Your membership dues, and it's $45 a year, are shared between this chapter and HLAA's national office, enabling both to put on informational programs and to advocate for services and public policies that people with hearing loss need to function and to thrive in the hearing world. Okay. Just one other thing, as I indicated, you'll in the chat box, you'll see a link, it's a fairly long one, but you can copy and paste it. And that's the link to become a member if you wish to do so. And the process, once you get into that, is fairly short and intuitive. And it enables you to join both the national organization, the National HLAA's organization, and this chapter. It's one process and a simple process to join both. Okay, enough. You're not here to listen to me. Our presenter today is Dr. Margaret Wallhagen. Dr. Wallhagen is a professor in the Department of Physiological Nursing, University of California, San Francisco. For many years, she has focused on the impact of hearing loss on individuals and families and how to enhance communication access, and has explored issues related to the impact some drugs may have on hearing. She has a strong record of community service and is a past chair of HLAA's board of directors. Welcome, Dr. Wallhagen. Thank you for being with us today. And so I will turn this over to you, and I think you should be able to screen share.
Thank you very much, Russell. And thank you very much for inviting me. I will screen share and get this going. Thank you all for coming and also for inviting me. And I will be sharing a lot in terms of ototoxic agents, medications that can affect hearing. Please do tell me if you have any problems hearing me, or I know I won't be able to see your faces, but I think Russell will be following the chat. So if specific issues come up, he'll let me know for sure. Meanwhile, what I'd like to do in the relatively short time that we have together is to first describe the concept of ototoxicity and how medications affect hearing. I'm going to be discussing key medications that are most commonly associated with ototoxicity, review some of the over-the-counter medications that may be associated with ototoxicity, and discuss the importance of putting decision-making about medications in the context of what is called what matters to you and your family. And I'll talk a little bit more about why I'm focusing on this as I go forward. Well, what is ototoxicity? Well, it's the pharmacological adverse reactions that are affecting the inner ear or auditory nerve characterized by cochlear or vestibular dysfunction, and vestibular being the balance part of our inner ear. Auto, obviously, as many of you would know, it means ear, and toxic causes damage. These drugs often can cause tinnitus or ringing, hearing loss, and or impaired balance. And we'll be talking a little bit more about what this can be temporary or permanent. This is sort of an overview of just the idea of ototoxicity. It can include both cochlear toxicity, which is the inner ear, which affects hearing specifically. It can affect vestibular toxicity, meaning the balance vestibular center, or neurotoxicity, meaning nerves in general. What we're doing today is we're focusing specifically on the cochlea and the impact that it has on hearing loss. But I think it's important, and I'll go over this again as we go forward, to realize that there are multiple things that come into play when we're thinking about hearing loss. And then there's ototoxic agents, which include a wide range of compounds, solvents, radiation, and I'll go into that a little bit more. But what we're again focusing specifically on today are the pharmaceuticals or the drugs. When we're thinking about medications, these are just some of the various categories that can be involved in ototoxicity. The pain relief in this overlaps a bit with the anti-inflammatory medications that we take for joint pain or other kinds of conditions that cause inflammatory processes. Antibiotics to treat infections, chemotherapy medications that are used for cancer, and diuretics or water pills that people often take if they have, say, heart failure or other conditions, including hypertension. So these are very common medications. But when you think about and talk about it, and it's one of the issues in terms of why I'm focusing on certain issues, if you look at the web or you look at some of the information that comes out, there are more than 200 medications that are considered either prescription or over-the-counter that are noted to have some potential cause of ototoxicity. They can affect the ear. So there's no cookbook, and I will keep reiterating that in terms of being able to say, I can't give you a list of drugs that say, these are all the ones that cause ototoxicity. What I will do is we'll talk more about the ones that cause more permanent damage to the inner ear versus the ones that seem to be more reversible. But I'll also sort of imply or talk about the fact that many times we need to consider multiple factors that are really important for you to think about when you talk to your practitioner or whoever is prescribing medications for you or thinking about therapy. Why are medications ototoxic? Well, unfortunately, medications have systemic effects. There are very few that can be precisely targeted. We can't give you a pill and it'll just go to your kidney or to your brain or to wherever. Unfortunately, when we give most medications, they go out throughout the body, and I'll talk more about that. So understanding the actions of a drug and how it interacts with our bodies can help us understand what the possible side effects are, both positive and negative. So these big words, pharmacokinetics, that just means the travel of the medication in the body. When I take a pill, when someone gives me an injection, whatever it is, it's what happens to that medication once it's there. Where does it go? How is it distributed around the body? How is it broken down so that I can get rid of it eventually? That's the kinetics meaning movement. And that's important because, again, does it get into the ear? Can it get in? Pharmacodynamics is what the drug actually does. It's the effect that it has. And so what it actually, how it affects the body once it's there. The pharmacokinetics, the reason it's important for ototoxicity, and when we talk about any drug, it's whether it's given orally or IV, intravenously, or intramuscularly, like a shot, the kidney function that we have, and liver function. And that's because the liver is extremely important to metabolizing almost all of our medications. The liver has enzymes that break down the drug, and that can make the drug either more active or less active. But the liver function is extremely important to getting rid of medications. So is the kidney. The kidney is important because that's how we eliminate many of our drugs. In fact, it's almost most of them. Some of them go out other ways, but mainly the kidney and the liver are very important to drug metabolism, to making it active or to getting rid of it, making it less active so we can get rid of it. how much body water or adipose tissue we have, and the drug characteristics. Does it dissolve well in water or fat? And the reason that's important is that some drugs, which are like to go into fat, they can stay around for a long time, because if we take them, it goes into a storage depot in our adipose tissue, and therefore it's drained more slowly. If it's water soluble, it's more in our blood systems and other parts of the water systems of our bodies. And so it doesn't store the same way as something that gets stored in the adipose tissue that may have a long half-life, meaning the time over which we can get rid of the drug. The ear is also important. The ear itself, it's one of the problems we've had in terms of studying the ear in general. It's hard to study because it's not very accessible. There's also what's called the blood-brain barrier, or the blood labyrinth, meaning the ear, to help keep drugs out. But these are not true barriers. How well they keep drug out depends on the characteristics of the drug. Again, whether it's water soluble, fat soluble, where it goes in the body, all of those things affect the action of the drug in the ear as well as in the body. What about the drug effects? Well, many factors influence the response to drugs. So the comorbidities or other health conditions that we have, they can exacerbate or make things worse, plus the fact that they also influence if we're on other drugs, which may interact together and work together to have side effects. Our age, because our body water and our fat levels change as we get older. We have less body water overall as we get older, and the adipose tissue tends to be more percentage. Even if you don't change weight, we tend to have more adipose tissue overall, and our kidney and liver function tends to change with age. So those make us more susceptible to many drugs because of that. So people have to be careful about dosing. Concurrent use of other medications, which may also be autotoxic at higher doses. So the combinations, and many times those have not been studied a lot. What's called the therapeutic window, which is the difference between the level of a drug that's needed to have an effect. I need to give you something to relieve your pain. You need a certain amount. Well, maybe that amount is close enough or is high enough that it's pretty close to where you get unwanted effects. That's very true of things like chemotherapy or cancer drugs. They tend to have a very narrow therapeutic window, which is one reason people do have side effects from many of the chemotherapies, unfortunately. So again, looking at the ear, the characteristics of the ear, it has a major blood supply. It's called the stria vascularis. And anything that goes in the body into the bloodstream can circulate and can get into the ear through that vascular supply. And once it's in the ear, it can circulate and affect the hair cells that are in there. This is where you get some barrier effect, so things can get through or some things don't. But in general, as I mentioned, it's not a complete barrier. So many drugs do get in that are in the vascular system. Well, how do they cause autotoxicity? And I'm going to mention this because these are the way in which these drugs cause what we call free radicals. They can affect drugs in many ways, but it's a fairly common way is through what's called oxidative stress. And you may have heard this because it's in common terminology that we talk about free radicals, and I'll mention antioxidant sort of thing coming into play. But free radicals, a free radical is an atom or a molecule with one or more unpaired electrons in its outer orbit that makes it unstable and reactive. That's like if you look at the little blue module on my left, it has 2, 2, 2, 2. So it's full. All of its outer orbit is full. This is obviously a schematic. On the right is one is missing. When a molecule is like that, when it has this unstable orbit, it doesn't like that state. It wants to react with something. So it will react with many different kinds of things, tissues and so forth. this is just an example. We create free radicals just by living because we use oxygen as a source of metabolism. Our cells use oxygen. The unfortunate side effect of that is that we create free radicals during the process of metabolism. Our bodies are very efficient at fixing the resulting of the free radicals. Fine balance. But you can see here that many other things can cause the development of free radicals. And unfortunately, free radicals can cause damage to our cells. It's an inflammatory reaction. It changes the DNA and so forth. So we try to correct that. Our bodies, again, do a lot to correct this. But the reason I'm showing this in a schematic is just to realize that it's the combination of things sometimes, not just one thing. So it may be a synthesis of all of the things that we're exposed to that help or exacerbate the problems that we might experience. Antioxidants can stabilize free radicals because antioxidants tend to give an electron. They sort of restabilize that molecule so it doesn't have the same negative effect. So that's true of when they start to look at how do we fix the damage caused by some drugs. The kinds of drugs, and this is where we're going to look at the categories that cause damage, include especially the cancer chemotherapeutics like cisplatin or carboplatin, various kinds of cancer chemotherapies, and antibiotics. Those are the two classifications that tend to be or cause more permanent types of autotoxicity. And unfortunately, the decision-making around cancer chemotherapy, it isn't like you wouldn't want it, but it's good to know that you can talk to people, and I'll talk a little more about that in terms of decision-making. But those are the two categories that have the most numbers of drugs that tend to cause or can cause permanent damage, especially if used across time. Some, if you have high levels of a specific drug given at one time, will cause a kind of pretty permanent damage unless it can be corrected really right away. Diuretics, excuse me, so those tend to use free radicals. They cause their effects by that system we just talked about. They develop free radicals in the inner ear that damages the inner ear. And I'll show a schematic of that in terms of where they're trying to make differences in terms of making sure that they can maybe prevent some of the damage. Diuretics and pain medications, excuse me, tend to be more reversible causes, if you will. And I say reversible, meaning that you may have some damage because the diuretics, for instance, may cause some changes in the vascular supply, either through changes in the fluid balance or changes in how much vasoconstriction, the vessels are constricted a bit and less blood gets there. These kinds of medications are often, or like with aspirin, you get sort of ringing in your ears. If you stop taking these medications, they tend to resolve. That said, because the issue of all the other stuff that comes into play, it's very hard to totally predict which one will be totally affect hearing loss long-term or permanently. And certainly if you have already some hearing loss, that can make a difference in terms of whether it could make it less, decrease your hearing a little bit more. So what are they doing? I mean, like the cancer chemotherapies. This is a messy slide, I know, but what I wanted to show you is this is a picture. If you look down the middle, it's taking cisplatin, which is one of the more common ones to cause autotoxicity, and shows that when it gets into the cell, it goes down and it creates these free radicals that change some of the characteristics of the inside the cell and causes apoptosis, which is basically death of the cell. So what everyone's trying to do is to look at, and this would be true of any kind of drug that works through free radicals, is trying to say, can we block some part of this schema to make it less autotoxic? And so they can look at it where they deactivate the cisplatin itself, which you may not want to do if it's a cancer chemotherapy, whether they can deactivate some of the inner cell types of processes that are going on, block or create, actually here, stimulate the production of those antioxidants, which can repair the damage, or block some of the other areas that cause additional free radicals. So all of these sites are where they're looking at ways in which they can minimize autotoxicity. One of the ones that I want to just mention, because it's come online now, is what's called this STS, which is, I'll show the next slide, this sodium thiosulfate. This can't seem to get that up there. That's approved. This has just been approved for the treatment to reduce chemo-related hearing loss in children with cancer. But it's very specific. What it is you can only use this. It's been FDA approved. It covers pediatric patients now. That doesn't mean that some people might use it off label for other groups, but it's for pediatric patients age 1 month through 18 years who have a localized tumor that has not spread, and it has to be given at 6 hours after the chemotherapy. And the reason is, this is where it looks at this whole idea of, if you have something that a drug is supposed to do, metabolizing it or getting rid of it may defeat the purpose of taking it if it no longer has the effect that it's supposed to have. And certainly with chemotherapy, you don't want to stop the drug from killing the cancer. So what they've done with this 6 hours is they've looked at what's the range by which we can give this medication and not impact the effects of the cancer, effect of the drug on the cancer. And they've come up with 6 hours. That said, we don't have long-term data, I don't think, on the outcome, but it has to very specific limits in terms of its effect. And you'll notice that it's also only for localized tumors that have not spread. So it's very specific in terms of how it can be used. But it is one of the medications that are now being approved, and shows that by looking at the ways in which the drug works, can we attack it at different levels and prevent the damage to hearing? So coming back to this idea, if so many medications we need to take are potentially autotoxic, is there something that we can do about that? And I think what I'd like to just share, it's not easy to have a cookbook. You need to think about yourself. What is it that I'm taking? And do I need to talk about what the effects are? And this is one strategy, at least, to think about how to think about medications or any therapy at that point, looking at the pros and cons. This is what's called the what matters decision framework. This has recently come into fore, mainly not that it hasn't been thought about before, but it puts it in a framework that lets us think about what matters to us. And it talks about what matters, medications, mentation, and mobility. And as this relates to, I think, our thinking about autotoxic medications, what matters in terms of this, what do I value most? What don't I want to stop doing? What are the outcomes I want or expect from a treatment? So it would be in terms of medications, in terms of how soon or what is the effect on me and what I want to do of the medication that I'm going to be taking. This relates to the medication. Does this medication affect my hearing or cause tinnitus? How will it affect doing what I want to do or like to do? What might be the alternatives if an autotoxic medication is needed? What is the lowest effective dose? Can side effects be minimized? Can another drug be deprescribed or canceled Because as I mentioned, one of the issues around drugs is they can be synergistic. And I did a study with a doctoral student where we looked at medications long-term. And as people had more drugs, even if they weren't considered autotoxic at the dose they were being taken, but they were being taken together long-term, there seemed to be a higher incidence of increased hearing loss in the group that had these multiple medications. So thinking about, do the drugs interact with each other? Can I get off one drug? Do I need all the medications I'm taking? Because I think most of us find that prescribers don't always think about the fact that you're already on other kinds of medications because they prescribe for a specific condition that they're interested in or they're treating you for. Will the medication affect my thinking? That's true of a lot of medications. So we want to use strategies to minimize cognitive changes in addition to thinking about the medication itself. And then mobility, staying active is very important to staying healthy. So does the treatment or medication affect my mobility, and how does it do that? One of the things that we certainly know about the medications for vestibular effect or for hearing is that both hearing and vestibular or balance issues, changes in the vestibular apparatus, affect our balance and can cause falls. So if you're on a medication that may promote falls, you really have to be more careful, and certainly, again, visual issues as well. So making sure that it's well corrected or being a little bit more careful. This is not so much a medication that is known specifically to affect hearing, but if you're taking sleeping medications, some of those medications, if they're over the counter, contain some forms of benzodiazepines, which aren't really good for older adults because they can affect cognition and it can affect falls as well. This is another sort of structured tool that helps us think about some of these issues around what matters, thinking about, and they just break these in, but it gives us sort of a framework to bring our attention to what is it when I'm going in and talking about the medications that I'm having, when I'm talking about the therapies that I'm having, make sure that I think about questions to ask the practitioner. How much does it affect my functioning? What are the important things to me in terms of my functioning, in terms of being able to enjoy life? If you're on certain medications, maybe it limits activities, or maybe it does affect your balance and it makes it harder. Connecting those kinds of things. And then again, this is just a framework that allows you to think about what it is and thinking about what matters most in terms of things that are important to you in terms of that bringing to the discussion. What is it that you like in terms of importance, in terms of medical decision making, your cultural background, controlling pain, financial considerations. Unfortunately, many drugs now, alternatives tend to be fairly expensive. How important is the input from your family in terms of decision making? So these are it's just a framework, but it calls our attention to how important it is to think about these things within the whole context of our life systems. So I think in summary, and I want to leave it open to many questions, many medications can cause either reversible or irreversible hearing loss, tinnitus, or balance problems. I think individual factors are really important. It's unfortunate we can't just give you a list in terms of saying avoid this, avoid that, and everything will be fine. It's not that easy, unfortunately. The dose of a drug, how long you have to take it, the concurrent health conditions, concurrent medications, genetic factors all play a role in whether a medication can cause hearing loss. Exposures to other toxic agents in the environment are also important to consider. Smoking, pollution, other inflammatory conditions, these all come into play as well. Generally, whether to take a medication or not should depend on consideration of the benefits, versus the harms of the drug. So always balancing that. Again, sometimes, unfortunately, practitioners they're thinking of the benefits. You want to know the balance. You want to let them know what you're taking in addition to the drug that they're giving you. You have to think about, am I able to take it at the times they want me to take it? Am I able to fill it in so that you may feel like you're taking many drugs, and we forget sometimes to take them. So it's important to have them know kind of how does it fit your lifestyle. And if the medication is needed, such as for cancer or a specific chronic condition, it's really important to discuss alternatives and whether there are things you can do to mitigate its impact. So on that, I really want to open it up to questions.
Thank you, Meg. Thank you very much. Let me check the chat box and see. See if we had anything here.
Oh, here's a comment that says that Noreen, that your hearing loss was tied to your day. So you had cisplatin. I think when the question looks at what would cause it, this is an interesting issue in that sometimes once the damage caused, and I will add that this is also true of noise. The data have shown that, and this is unfortunate for young adults too, when people have been exposed to loud noise, they sometimes have some effects immediately in terms of either tinnitus, ringing in the ears, and or maybe a slightly diminished ability to hear. But what they've noticed is that even if that resolves in the short time, when they look closely, and they say this is not easy to do, and it's unfortunate why they use other models than human, is that the damage may be continuing. And I think that may be part of the reason that it progressive. There's probably more factors that are going into play there. I don't know what else you're on. And of course, our hearing does tend to change as we get older. We tend to have more difficulty hearing, especially with high frequencies. But it's not unlikely that some of that relates to some ongoing free radical and other damage.
Thank you. Let me ask a question, if I might.
Sure.
What you're describing is a necessarily complicated process of evaluating situations. You know, a whole lot of factors. I guess what I'm really wondering about is where to find support. Does the medical profession understand this? If I need chemotherapy, are the docs that I'm going to be talking about likely to be of help in making decisions, you know, based upon the, you know, the various factors, you know, particularly, you know, of concern to me? Okay, let it go at that.
Yeah, no, I'd like to say yes, but what you're raising is something that we've tried to bring out more in terms of the knowledge base of practitioners. There is what's called, well, say with chemotherapy, I would say no. I would say that one of the things, unfortunately, is that here's where a place where you probably do need to be advocating for yourself and asking questions. You already know, in many cases, many of you know that you have some hearing loss already, but certainly making sure that they test your hearing before, talk about the fact in terms of what the alternatives are, talk about dosing, talk about other things that may be known to the individual that may minimize the side effects. And so it's something that you probably need to raise. And then also asking for sure, if you can, is there something that you're taking now that could be stopped, maybe temporarily, while you're having the chemotherapy? Would that make a difference? And it's also where you could certainly ask to talk to a pharmacist who hopefully will have a better sense of what's going on. I think geriatricians, people who work with older adults, those of us who are interested in care of older adults, would be able to sort of discuss those issues. But it's something where you need to sort of bring it up yourself. There's also, although it's called the Beers list, it's BEERS, that the American Geriatric Society puts out. It's a list of drugs that are not, this is not focused on hearing loss, but it addresses issues around what medications should be potentially avoided as we get older. And they don't mean absolutely. There are a few drugs on that list that they think really shouldn't be prescribed as we get older, but it's more of a listing of medications that one would ask specifically about, is this needed and why is it needed? And they may be needed for sure, but just in terms of being careful. And some of these drugs, they know have more side effects in older adults than they might in younger persons.
See, there's a
And I
question.
think there's a question about the
Antibiotics.
antibiotic. No, it's a good question. There are certain antibiotics that are more pertinent than others. Certainly the gentamicin, that's one of the classic ones. But yes, some of the other ones, it's not all been studied specifically, each one individually. I know I looked at one study that looked at long-term use of an antibiotic, and it seemed to affect the hearing. And I didn't see a follow-up in terms of whether that was reversible or not. But it's, again, why you would want to ask specifically about the drug itself and look at the literature on that, or the write-up about the thing, because I know it's in small print, but they always give you those handouts, and unfortunately they don't always include hearing loss, unfortunately. But it hasn't been studied as much as it should be.
I would assume, let's see.
I can put the beers, I can.
Were the drugs Wendy, do you want to explain, you've got something here on the chat box. Maybe you can explain it a little better than I can.
Yes, on one of the slides, there were some drug names that were bolded and most of the others weren't. And I just wondered what the significance was.
I think the ones that were bolded are the ones that were more commonly, that are more known about. I mean, the ones that, when I listed the chemo, certainly the cisplatin and those particular medications are especially known to be problematic from hearing loss. That's been known for a long time. And also that's true of gentamicin and some of the antibiotics. Some of the other ones haven't been studied as much. And I searched online for all, and sometimes you get these laundry lists of medications, but they're not really always helpful, because again, you have to think of the context and what else you're taking, as well as that medication itself. And is it reversible? Many of these are, generally speaking, potentially reversible if you're not taking them for too long and you don't have other concurrent things that exacerbate or are synergistic to the effects of the medication.
I have one more.
If
I have another question, if that's okay.
Go ahead.
Thank you. Is it possible, I was diagnosed with Meniere's disease by process of elimination, but I had really bad allergies, and I may have been on erythromycin. Are those ever mixed up? I mean, I guess there's not a definitive diagnosis for Meniere's disease except eliminating everything else, but the symptoms seem that they would be similar to what you described.
Well, yeah, I think that Meniere's disease can be caused by a lot of things. I think if the effects on your hearing from the antibiotic were such, it could be a precipitating cause. I can't say for sure, but certainly it could be compounding whatever was going on.
Is there a
And
concern?
the low frequency loss they mentioned, well, yes, if it's causing damage in the inner ear, the type of loss may differ. So I wouldn't say it can't be. I mean, they don't, on many of the drugs, they don't specifically say it's high frequency or not, except that cisplatin tends to be more the high frequency from my understandings and my readings of that. But yes, certainly it could be cause low frequency as well as high frequency.
Is there a concern? Let me, I'm going to put myself on here. I'm an old guy, but as a kid, I had ear infections, which is not uncommon for kids, small kids, but what was uncommon, or maybe wasn't uncommon at the time, is how they treated them. They treated me first with X-ray, and that didn't work. The infections continued, and so they went to Plan B, and that was radium.
Oh, wow.
Yeah, I mean, this all sounds nuts, but they really did that. And at the time, it seemed to me that it worked, or at least the ear infection stopped. Whether that had anything to do with the treatment or whether I just grew out of it, I don't know. But then 40 years pass and I developed hearing loss. And I've had physicians tell me, there could be a relationship there. And I'm just wondering whether those kinds of long-term things, is that likely? Is that something to be concerned about? I don't know if there's anything we could have done about it.
There's nothing you can go back and change, right? Well, it depends on where they put the radium, but it was, again, like when we talk about the co-occurrence of stuff, yes, there are genetic predispositions to these conditions, just like why some individuals start getting hearing loss earlier because they're genetically predisposed to hearing loss, as well as the fact that if we've set up something and maybe it was a relatively early change, but maybe your threshold wasn't as high to start with. It's kind of like bone health. If you don't get really good bone health when you start losing it, it's a lot easier to get the fracture threshold than if you have really good bone health to start with. So it does matter probably in terms of where your hearing is, and then because the trajectory will start at a different level when we start losing some of our hearing capacity, or tend to. But a lot of factors come in: the exposure to noise, the exposure to other kinds of toxics in the environment that we half the time are not even aware of, whether we smoke, whether we have cardiovascular disease, because that affects our circulation. And circulation to the ear is extremely important. So we know that hearing loss is more common in persons who have diabetes, with persons who have cardiovascular disease. So our physical health can be really important to minimizing hearing loss.
Other question, I don't see any further questions in the chat box, but it's a relatively small group. So if there are further questions, I don't want to cut this off prematurely. Why don't you just unmute yourself and proceed? We'll see if there are other questions.
If you really have questions, I certainly am not a pharmacist for all the different drugs that are there, but if there are questions that I can answer, and maybe Russell can send me those questions and I can see if I can provide any answers. But it's hard in specific situations many times because in truth, it really does matter in terms of the contextual factors. Because it's so hard and a talk like this is difficult from the standpoint of being able to give you a textbook or a listing of specific drugs. It's being aware and really looking at the characteristics of the drug and looking at how strong the data are. Because when you look online, many times you'll get a laundry list of medications, but whether that's a one-time complaint because they have to list all the complaints versus something that really does have an effect is something that it needs careful review or careful consideration.
Can I speak? This is Gloria Lloyd. I recently had knee surgery, and due to that, I need to take antibiotics for anything at all that's in the least invasive, including dental appointments. And I have to take that for the rest of my life. Now, some surgeons feel that it's not necessary to take it lifelong. Maybe you can get away with only doing it for 2 or 3 years, but my surgeon says he prefers lifelong to be on the safe side. So when I get these prescriptions for the antibiotics, every time I have a dentist appointment, do I have to be careful which prescription it is? Are there some antibiotics that would be better, some that would be worse? And I also want to mention that as far as I can tell, my hearing loss is related to having taken anti-malaria medication
Right.
for about 2 years when I was posted to Ghana early in my foreign service career, because I passed all the exams for the foreign service, went
Sure.
into it, took the anti-malarias for 2 years, and at the end of 2 years, I needed a hearing aid. And it's been going down ever since. And I just recently got a cochlear implant. I was just activated just a few days ago.
Congratulations.
So here I am. But at the same time, I'd like to protect whatever is
Sure.
left of my hearing in the other ear that I'm wearing a hearing aid for. So all of those
Well,
questions together.
Yeah, that's a really good question. For one of the things would be how long you have to take it at the time of the dental procedure. So if it's a relatively short time, it may not be as, now if you're on chronic therapy,
It's
then
just the one day.
just for, if it's a very short time, I would still look to see and really ask and say, can you talk to the pharmacist? And are there other things within a category that would be less likely and yet still work? And that it is a really hard thing because I have to say myself, I was just on a long course of antibiotics because of some oral surgery, and he wanted me on for, and I kept arguing back because I kept saying, are there problems related to hearing loss on this? And I searched, and the data weren't that strong, but still I was very concerned about it. So I would definitely just ask and say, speak to the pharmacist to see if you can have the least amount and the lowest dose that you need to be able to cover you, or that he would feel would cover the situation. It sounds like you don't take that much, but still, if it's pulsed and you have other medications, then you can tell the pharmacist or the practitioner, I'm also on these other medications. Do they also act together?
As long as it's not dental surgery or anything like that, if it's just routine, then it's just for the one day.
Yeah.
Should there be dental surgery, then it would be something else. But so far, that has not been a concern, just cleaning and that sort of thing. Whatever.
Wow. Interesting. They're being very careful.
They are, because
other
infection in
questions?
the knee could cause you to lose your leg, and obviously that would
Well,
be
you don't want that.
a
Yes.
huge loss.
That's again one of those things where you're
Right.
looking at what are the pros and cons. Yeah, unfortunately, it's like chemotherapy. You're not necessarily going to
Exactly.
chemotherapy because it affects your hearing, unfortunately.
Other questions? Well, if not, I see.
Oh, I'll ask a question.
Go ahead.
It might be a dumb question.
No, there aren't any dumb questions.
And thank you, Dr. Wallhagen. It was a very informative and interesting presentation. I was curious if there's any over-the-counter pain relievers that are not ototoxic. because I think I'm like addicted to ibuprofen, and I get to a point where I don't care, even though I know it's ototoxic, but I'd rather not have a headache.
Well, it depends on what, I mean, I would find out more about why you're having headaches. I mean, how often you take it and how long you take it. I mean, 1 or 2 pills are not necessarily going to cause problems, I don't think. If you're on it chronically, then I would start looking for, I'm not sure if Tylenols are that much better, but it's not as much of an anti-inflammatory. I mean, some of these drugs constrict vessels. And one of the things about the non-steroidals anyway, like ibuprofen, it blocks a substance, cyclophosphamide, that sort of can cause issues around vascular constriction. So that's why, so I would just look at whether you're taking it a lot, and whether, you can, especially if you take multiple ones, can you interspace them so you don't take too much at one time, and maybe take, if Tylenol works. I know some people find that the Tylenol doesn't work always, or the ibuprofen seems better. But I would really look carefully, and also making sure is there another reason for the headaches that might have a better. If it's a migraine, there are different medications that affect migraines.
Okay, right. So, but Tylenol was on your presentation,
Well,
right?
it's one, but these tend to be sort of reversible, and the data again are not strong on some
Okay.
of those medications.
Okay.
So,
Thank you.
Wendy, you have your hand up.
Thank you. I just wanted to say something in relation to that question. I can't take drugs for other reasons. I'm really sensitive to drugs. And so to the extent possible, plus I ended up in the emergency room with bleeding ulcers from SAIDs. So I've learned a lot of other ways of controlling pain. I was in a bad car accident and I had like 15 kinds of pain, but I couldn't take any drugs. And so you might look into integrative medicine, because acupuncture is a great alternative for some kinds of headaches. I use homeopathic remedies too. Arnica montana is really well known to work for muscle pain and other kinds of inflammation, but you might want a practitioner to help you. Aside from that one's pretty generic and it doesn't cause any problems. That one I use, like if I wake up with muscle pains because I've overdone or something like that. So there are people out there who can help you with other ways of treating headaches.
Thank you. Can you put that in the chat, the one you mentioned that you said was generic? I wasn't able to.
Yeah, you can get it at Whole Foods or any, but ask them about how to take it, because it's important not to take it right after you eat and not to drink coffee. They work very well, and you can't touch them. You have to take them off a spoon, because the active ingredient will come off in your fingers and then you'll just be putting sugar pills in your mouth. So you have to know how to use them. But at Whole Foods, the person who's working in the aisle can probably help you with that.
Can you she was asking about the spelling, I guess.
Yes.
Thank you.
It also,
I do think, I mean, that's where a pain medication, sometimes if you're not so much for a headache, because it doesn't work very well, but you can use topical medications. Some of those are over the counter and they don't have the same absorption. So for many kinds of pains, certainly I'm very sensitive to medication too. So I tend to use over the patches or the cream or something like that that's topical, figuring that doesn't have quite the same effects. Other questions? I really appreciate and I'm sorry I can't give you a laundry list and specifics about all the drugs, but hopefully this will give you a framework that will help you decide more about what should or what should not be taken.
Wendy has put in the chat box a comment that says, "Thank you very much. This was very helpful." And I want to second that, because I certainly found it very, very helpful as well. And I want to thank you Thank you so much, Meg. And thank you also to Lisa, you know,
Yes.
for the captions. You did a terrific job as usual. And thank everybody for coming. And hope everyone has a great summer. And we'll see you in the fall. Thank you so
Thanks so
much.
much.